Hey guys, welcome to my channel Document School. If you're new here, consider subscribing and hit the bell icon so that you don't miss out on the new videos. Today we're going to discuss about Barrett Esophagus. Barrett Esophagus. Barrett Esophagus is a complication of chronic GERD, also called as gastric esophageal reflux disease, that is characterized by intestinal metaplasia within the esophageal squamous mucosa. What is GERD? GERD is a disease or a group of conditions that happen due to the reflux of the acidic contents from the stomach into the esophagus or into the small intestine. Now, this acidic content that has been refluxed back into the esophagus or into the small intestine causes the mucosal epithelial changes. This change leads to the production of intestinal metaplasia in the esophagus. Approximately 10% of the individuals with this GERD, symptomatic GERD, have Barrett esophagus. The greatest concern in Barrett esophagus is that it confers an increased risk of esophageal adenocarcinoma. Now, is it okay to say that Barrett esophagus is a precursor lesion to cancer? Yes. You know why? Because the genomic sequencing of biopsies involved by Barrett esophagus has revealed the presence of mutations that are shared with esophageal adenocarcinoma. The presence of dysplasia, a pre-invasive change, is associated with prolonged symptoms, longer segment length, increased patient age, and Caucasian race. Morphology. Barrett esophagus can be recognized as patches of red, velvety mucosa extending upward from the gastroesophageal junction. This metaplastic mucosa alternates with the residual smooth, pale squamous esophageal mucosa and interfaces with the light brown columnar gastric mucosa distally. As you can see in the figure down to the right side of the screen, the smooth or pale pink, little bit pink type of tissue that you can see is the squamous mucosa or the esophageal mucosa, and that interface between the light brown columnar gastric mucosa, that's the gastric mucosa, like the metaplastic change that has happened in esophagus. And as you can see the histologic photo of that scenario, it has you can see the interface between the stratified squamous epithelium and the columnar epithelium with goblet cells of the gastric mucosa, the interface between those two. Diagnosis of Barrett esophagus requires endoscopic evidence of metaplastic columnar mucosa above the gastroesophageal junction. Now, with high resolution endoscope have increased the sensitivity of Barrett esophagus detection. This has led to subclassification of Barrett esophagus into long segment and short segment. Long segment being 3 cm or more in length and short segment being less than 3 cm. Dysplasia is present and it is classified as low grade and high grade. The similarities between both low and high grades are atypical mitosis, nuclear hyperchromasia, irregularly clumped chromatin, increased nuclear to eosinophilic ratio, failure of epithelial cells to mature as they migrate to the esophageal surface. These are the similarities between both the grades of dysplasia. High-grade dysplasia exhibits more severe cytologic and architectural changes or architectural irregularities. These architectural irregularities, including gland-within-gland architecture or cribriform, can be seen in the histologic slide here, with the photo of the histologic slide. And this gland within gland and cribriform are the architectural irregularities which are seen in some high-grade dysplasias. Clinical features. Barrett esophagus can only be identified through endoscopy and biopsy, which are usually prompted by GERD symptoms. The best course management is periodic endoscopy with biopsy for dysplasia surveillance. Although there has been a lot of debate on the periodic endoscopy and periodic surveillance on the patients, because the randomized trials showed that surveillance or periodic endoscopy has not shown any improved patient survival rate. Multifocal high-grade dysplasia, which carries a significant risk of progression to intramucosal or invasive carcinoma, intramucosal or invasive carcinoma requires therapeutic intervention, and this multifocal high-grade dysplasia is considered as an intramucosal or invasive carcinoma in order to prevent it from actually being turned into intramucosal or invasive carcinoma. And for these, the treatment options are surgical resection, esophagectomy, photodynamic therapy, laser ablation, and endoscopic mucosectomy. So that's it for this video. I hope you guys enjoyed it. I'll see you guys in the next video. Till then, bye bye.